expanding on that to look at the strategies to reach the quintuple aim. But before we move to our excellent panel, what I wanted to do is just to revisit this idea of the quintuple aim. I actually laughed this morning when Dr. Christensen talked about how many aims can we stuff in there. And what I thought we might do is start with the triple aim. And you might recall the triple aim is the combination and the three aims that we are looking to achieve: of population health, care experience, and um, achieving some efficiency in per capita cost. But I have to admit, when I consider the triple aim, I actually often like to go back to the iron triangle. And the reason I like to go back to the iron triangle is particularly when we think about the challenges that rural and underserved communities face. To be able to name that issue of access is really important. I think the other really important component of the iron triangle is the concept of the iron triangle. It reminds us that you can do each one of these in trade-off to the others. And when we start thinking about trade-offs, I actually think that's why it's really important for us to include the clinician experience and to include health equity and make it a quintuple aim and not just the triple aim. Because I think, as has come up this morning, for clinician experience in our last panel, clinician experience, oftentimes as health systems, health organizations have been working to advance access, quality, and cost, those aims, we can do it at the expense of clinician experience. I think we're starting to realize that long term, that doesn't work. But short term, when you do that, it starts to put us into a cycle that can be really hard to get out of. And then the issues of health equity. Again, I think Dr. Christensen really highlighted this of incredibly, people have been working on these issues of access, quality, and cost at the detriment to health equity, sometimes worsening disparities. And so it's really important to keep both the clinician experience and the health equity issues visible as we work to address the other three aims. Now, what I am excited about, though, is that we've talked a lot about the challenges. I think that when we look at the workforce numbers, they always look quite distressing, and they really do highlight the challenges of rural America. And again, Benjamin in our last session really highlighted some of the challenges of both delivering healthcare and recruiting a workforce into rural communities. And now we're going to turn towards opportunities. And one of the things I think that is always really important is as I think as has been highlighted, oftentimes when I think about rural and underserved communities and health systems often lean very heavily into mission. I think that we heard that very clearly in the last session. And it is amazing when people are mission driven in some tight resource settings, what they can do and what they can innovate, what they can come up with. And I think that this is what this panel is about. And very briefly, I thought, gosh, I should come up with an example. I will tell you, one of my first thoughts was to talk about dental therapists, particularly dental therapists, this still relatively new profession that came up in Alaska in tribal communities, and the impact that it's having in those communities, as well as for the well-being of the teams that they're working on. But then I thought, wait, let me do a local example. And one of the examples that I just loved, I know I have two children. I know you're not supposed to have favorites among your children, but I hope it's okay to have favorites. It was about a year ago, I guest edited a special issue of Family Systems and Health, and it was about integrated team-based mental health care. And Dr. Eve Lynn Nelson, and if you're here at KU, maybe you know her, Dr. Eve Lynn Nelson submitted a paper, and it was about a program to increase access to mental health in rural America. It was actually built off of something called Telehealth Rocks, but that was the existing program. It also shows you that she's very good at naming programs, but Telehealth Rocks has actually been in place for a couple years. What the paper actually was about was building off of Telehealth Rocks to embed community health workers into schools in rural communities. And I have to tell you, as somebody who has followed the workforce and followed these innovations for some time, it just blew my mind, the innovation that was happening, and the creativity, and when people are mission driven, the things that they can achieve. And so We have an amazing panel today. We have Dr. Anna Ratzliff, who is from the University of Washington. She's the Director of Integrated Care Training Programs at the University of Washington and the co-director of the AIMS program, which is the Advancing Integrated Mental Health Solutions Center. We have Dr. Greg Ator, who is the Chief Medical Informatics Officer at the University of Kansas Health System. And you can see that Dr. Ratzliff is going to be talking about successful models for team-based integrated care. Dr. Ator is going to be talking about rise in technology solutions. So you can kind of see the connection to the case study that I gave just now. But I'm also really excited to introduce Dr. Natasha Bray, who is the Dean of the Oklahoma State University College of Osteopathic Medicine at the Cherokee Nation. It is the only tribally affiliated medical school in the US. And I think it also really, really highlights the importance of remembering that for rural America, for underserved America, it's not just about the incentives in place for how healthcare is delivered and supported. It's also about the who and how we train, and the importance of doing this. And just with that concept of, it's amazing what people can do when they are mission driven. I have to share, in the speaker room, before we came upstairs, I got a chance to meet Dr. Bray, and while I've been following the school, I did not realize that they will be graduating their first graduates this coming May. But if you do the math, that means their first class entered in 2020, in the first year of COVID. And it just, again, reminds me of when you have mission-driven people, what they can do. And so, Dr. Ratzliff?
All right, so I'm very excited to be here and talk a little bit about integrated care as one potential solution. I am a psychiatrist by training, and I've spent most of my career actually delivering mental health services in primary care settings and helping other organizations do that. So I'm really excited to share what I've learned from that experience. So I'm going to talk about collaborative care, and lots of care is collaborative, so I just want to acknowledge that up front. But this is actually the collaborative care model, which is an evidence-based, team-based behavioral health integration strategy. So we've talked a lot about sort of where we are, and I just want to give a little context for mental health care to talk about why some of these things that I'll speak to are so important. There are a lot of people with common mental health disorders out in the United States. I think most of us who are in healthcare understand and appreciate that. Depression is a leading cause of disability. This is a treatable condition that actually most people, unfortunately, are not able to access effective care for. So many of the people that struggle with mental health disorders don't get treated, and many of them want treatment. So I think that this is a really important context to understand why we need innovative solutions. It's also really important to understand, and I think there was a little conversation about this in one of our earlier presentations, that there's an increasing recognition that a lot of mental health care is happening in primary care. So when we talk about access to mental health care, it's not just about the number of psychiatrists and psychologists, but also many of our primary care providers are an important part of that workforce, with about 60% probably of mental health care happening in primary care settings. And there's a lot of reasons why that's happening. I think there are patient factors. A lot of people don't make it through our complex referral system to actually access the services that they might have officially through their insurance. And when they do sometimes make it, they often don't stick. I think there's a lot of complexity about why that is. But I think especially as we're here talking about rural, you can think about distance as such a big barrier. And there are also provider factors. So this is a map of the United States with county level data. And what you can see here is that all those gray boxes have no psychiatrist at all in them. There are other providers, so I don't want to diminish that, but I think it's really important to understand how limited sometimes the access to that expertise is across the United States. So I am not going to just talk about doom and gloom. I want to talk about some solutions and some things that maybe actually can help with this, these challenges. So I'm going to talk about the collaborative care model. which is abbreviated COCM as opposed to the chronic care model, although that's actually what it's built off of. So this is a model that was really developed and tested, trying to take the ideas of chronic illness care and really adapt them for mental health services. So in this model, it is a patient-centered model, and I think that's a really important thing. It starts with that patient in the center and that relationship of that patient with their primary care provider, and getting access to care in a setting that they often feel more comfortable accessing care in. And what this model does is add two team members to really support the delivery of mental health services right there in primary care, where patients are coming anyway and actually maybe more um, comfortable actually accessing care. And those two people that are added are a behavioral health care manager. The people who can serve in this role, there's a lot of different ways to actually build. It's a role, it's not a profession. And I think that's a really important concept for us to be thinking about as we think about solutions. What are the things that people need to be able to do in that role? There are really two pieces. One is care coordination and bringing the team together, facilitating communication. The other is often delivery of brief behavioral interventions in primary care settings. So this is access to psychotherapy, which is actually a preferred treatment for many patients who are engaged in mental health care. And then a psychiatric consultant. And again, this can be served, the role could be served with anyone who has, as part of their licensure, prescribing of psychiatric medication. So there's a number of professions that can serve in that psychiatric consultant role. The way that this model works is a patient will come in to primary care, be identified, often using measures like a PHQ-9, um, be identified by that primary care provider as needing services, and be connected to that behavioral health care manager. That person often serves to really do additional assessment, right? Complementing that skill set and honestly, the availability of that primary care provider in their 10 or 15-minute visit often can't do a lot of more complex history taking, really helping with diagnostic clarification to make sure we understand what we're actually treating. So that behavioral health care manager complements that skill set of that primary care provider, helps with making sure that there's a clear diagnosis identified, and then that there's actually a treatment plan developed with input from psychiatric expertise. And most of that is done through a weekly consultation between the psychiatric consultant and the primary care behavioral health care manager. They use a registry, and that's really important because one of the things that often happens is that people get identified and then we're not tracking and making sure that those people actually get better. And so the behavioral health registry actually puts every person that's identified on a list, and we're going to keep them engaged in sort of additional surveillance and support until they actually get better in that episode of care. And the psychiatric consultant actually doesn't see most of those people in person. So you can see that's a dotted line. That's because they only really will actually do direct consultation to the primary care provider or the patient as needed. So they're really triaging how they're spending their time, focusing on the patients who need diagnostic clarification, treatment planning, those kinds of things. So this model has now been tested in over 90 randomized controlled trials. And I think what's really exciting is over those trials has really been demonstrated to achieve this quintuple aim that we just heard is such an important target to be thinking about as we think about solutions, right? This is a structural solution to the lack of access to behavioral health care. And when this model is delivered, you can see increase in both access, but also improving clinical outcomes. There have been studies that have shown that actually delivering this model and getting people better can reduce total costs of care. Generally, those are actually savings in medical care costs in the subsequent years from an episode of care. We have good data that shows that this actually improves provider experience and satisfaction and can help them with productivity, that there is improved patient satisfaction, and that we have a good amount of data that when this model is delivered to fidelity, you can reduce healthcare disparities, giving people access to effective mental health care that often are populations that is not common. So this is just one of those trials, and I just want to give you some examples. So this was actually the largest trial to date that was completed by Dr. Unitzer, who is our chair of our department. It was 1,800 patients at 8 organizations. And what you saw is that every single one of those organizations, when you delivered care, organized care, provide a structural support to delivering care in primary care, you got more patients better. There also have been subsequent studies that have been done out in real world settings. The little box at the bottom is a Mayo Clinic study. And what it showed is that in their clinics that were delivering collaborative care, they could get a patient better in about 86 days compared to their usual care, which was probably 614 days. That's when that you saw that remission of depression. So this is a model that works across depression, also comorbid with medical illness, anxiety, PTSD, chronic pain, dementia, substance use disorders, and bipolar disorders. So really something that probably can be an answer to a lot of the behavioral health conditions that would be showing up in primary care settings. I want to kind of highlight a few of the things that I think are a real benefit of this model. The first is that it allows you to leverage scarce behavioral health resources. So while we don't have enough people to actually probably meet all that need in our traditional ways of taking care of people, this model has a couple of advantages. First of all, that behavioral health care manager and the primary care, the psychiatric consultant can both be virtual. So this can have the ability and the figure there over distance shows my experience. So I was in King County in Seattle, and I was taking care of clinics across Washington State. I had, when I was doing this work, about 70% of my time, I had 10 clinics that I was working with. And I was able to actually provide a lot of care without having to travel to all those settings by supporting that behavioral health care manager and that primary care provider that were out in some of our rural communities. One of the things that I was really able to do is use my time in a different way. So instead of maybe seeing 8 to 10 patients in a typical day, if I was doing those assessments directly, or even over telepsychiatry, I was able to support 3 care managers, each of those folks taking care of about 60 patients. So you could imagine my population impact as a psychiatrist was really leveraged through building this team-based capacity. I think it's really important to note that one of the things that made this work really rewarding to me, though, was that we did measure whether or not patients were getting better, right? So I know that even though I wasn't doing direct patient care, which was maybe what I had been taught through all of medical school and all of residency, I had data that showed that I was getting people better. And that accountability was really important to me to feel confident in this model as a provider. I also just want to say, both from my personal experience, and these are data from studies, that, my experience of this work is that it really was a different experience for the providers getting the level of support that I'm describing for their practice. When we looked at studies of primary care providers, 90% of them, even if they were a little skeptical at the beginning, they're like, I really wanted that person to refer out to. Once they saw the kind of support that they could get from the psychiatric consultant and that behavioral health care manager, they were really satisfied with getting that support and being able to actually provide the care that they really wanted for their patients instead of, sending people into a referral void, right? And that heart sink feeling, knowing that that's going to be so hard for your patients to get the actual care that they need. Our behavioral health care managers are often, the main behavioral health provider out in a primary care setting. And so one of the things that they talk about is that by being in a team-based environment, they're getting support from an expert every week, that psychiatric consultant. And a lot of them talked about how helpful it was to not feel alone in their setting, trying to take on all of the behavioral health complexities. So I always made sure that that was a big part of our conversations every week when I was doing this work more regularly was, how are things going for you, right? Like this care manager, how do we keep them feeling engaged and supported doing this work? And I think that's nicely represented by this quote, which was actually from one of our recent studies looking at how to do this work for bipolar disorder. And then the psychiatric consultants talk about that it's also really nice and engaging to be able to provide mutual support, right? Being able to help patients that have a complex presentation actually get the care that they need. So I think that this is an important kind of model to talk about. How can we take structural change to actually improve the experience of the people providing care? And that's a really important strategy as we start to think about workforce wellness. And that's the end of my presentation.
Good afternoon. My name is Greg Ader. I am a practicing ENT physician and the Chief Medical Informatics Officer here at the Kansas Health System. And I think I have an hour. No. I will start a timer because I could go on. There's a lot to talk about, but what I'm going to talk about, I think, is really something that is really on the minds of every physician and provider, and even extends into other types of clinicians. Really, documentation. I think we've already heard about AI, and so the incredible opportunity I have to talk to you today is about marrying those two concepts. And it's funny, my wife was working on our Christmas card, and we've had a marriage in the family, we've had graduation. She said, Greg, what should I put for what you've been working on this year? And I said, thought a little bit. I said, I'm protecting the doctors from the EMR. And I really believe that's not an overstatement of my role. I'm really incredibly concerned about the provider experience, and no disclosures. Um, and I think we have a breakout, so perhaps I can do some of this at that. But what I'm going to talk about today is generative AI, a fairly, I think, straightforward application of AI, and I think it's a great place to start in medicine because I think there are potentially some great issues that we need to really keep our eye on as we deploy this technology. And today, it's generative AI is the focus, and that's really not replacing the doctor with a computer. That's there are issues, and I'm just going to allude to a few of them in terms of bias and those sorts of things. But I think we can largely avoid that. The topic again is how can we use it for documentation? And I do have to have one joke. The doctor used ChatGPT to pass the medical school exam. As we've seen, it can be done. That's not what I'm talking about. So what I am talking about is extremely practical, and that is how can we use data like the clickstream data that all of the big vendors collect on our providers that shows what they're doing, and documentation, in-basket review, data review, and then orders. Those are really kind of the four big buckets of things that docs do with the EMR. And I have data that shows really, you can see that the purple, which will be prominent in this presentation, is notes and letters. The legends there on the right. In basket is blue, and then clinical review, hunting and gathering, we call it, for information in the record, and then orders. So this is a new provider. This is actually one of our clinical informatics fellows who sees patients in addition to learning about informatics, spending a lot of time as a new provider, new to Epic. That's the system that we use. It doesn't matter. What I'm talking about doesn't apply to brand names, but he was spending a lot of time. And so that first red bar at the bottom is 8 a.m. to 6 p.m. So a full day of playing with the computer, so to speak, and most of it is notes and documentation. This is a provider. This is data from last month that works at our place. Starts at about 6 o'clock and goes all the way to midnight. Does slow down a little bit around the dinner hour. And that's a very concerning pattern, I think we can all say. Look at this one. That's 2 o'clock in case you can't see it when they're shutting down. So you can see a lot of notes activity during the workday, and then a lot of in-basket activity This is not good. And this is exactly what we're trying to address. This really, and this is going to be if you remember one graphic of my presentation, this might be number one, but this might be number two. This is from Jim a few years ago, a child that was involved with an exam, and you can see over here, this is the doctor, back to everyone. This is the patient playing with the computer. And so that is not right either. So the current state, documentation, as you can see from this data, and there that we have lots of that on each provider. What we do right now is we listen to the patient, then we try to type, talk, think, and listen. We all know no one can multitask. Even our kids can't do it, and certainly at my age, you can't do it. So something gives. But when we leave the room, if we have given up on type, talk, think, and listen, and then we translate it, basically re-enter that conversation and into the record. And of course, the common thing is, that patient is tapping their toe right now, wanting me to come see them. So the natural tendency is I'll save the charge to the end of the day. And that is the kiss of death, because of perhaps you're seeing 10 hip replacements in one day, they all run together. And then you have to recreate, was this number 7 or number 4? And so really not a good state. And then you always be communicating. So we need help. And the current interface of typing and clicking is really not cutting it. I think it's interesting that we've got this rise in generative AI, and I think of course there's a number of factors there that I won't go into, but I'm glad it's there. I'm glad it's here. So we saw that we had a problem, and we went out looking really for a solution, and we sought out a startup vendor that we've actually used a lot of different vendors, including some very big names of technology. But what we find is that trust and avoiding that problem with you may have heard of it, of hallucinations and AI making stuff up. We just have zero tolerance as physicians for that. So we really needed a product that sort of understood that. The product that we actually, or the company that we decided to partner with early on is called A Bridge. And they have some very talented scientists that work for them, in addition to being run by a physician who understands this trust piece that I'm talking about. And Dr. Lipton just appeared before the Senate to talk about some of the risk that, again, I won't have time for today. But this is one of their landing pages. I want to care for patients, not paperwork. So we thought, this is starting to resonate with where we want to go. So we evaluated a number of the vendors, and again, we have I think a good approach to AI governance. Again, no time for it today, but really, your organization does need to think about how are we going to govern AI in regards to all of the usual things that we've been hearing about: equity and fairness, disparities, and that doesn't necessarily come from the marketing people at the company that you're buying your product from. So the documentation, I described the current state and the untenable nature of that. The future state is really what I want to just talk about a little bit. Is I essentially start an app, just set the phone, it's on both platforms, set it down, and it just listens. And I essentially have a conversation with the patient, and then when I leave the room, essentially instantaneously a summary, not a transcript. None of my colleagues want to read some stuff about the Chiefs, maybe about maybe not this week, but anyway, it cuts all that out, and my daughter's marriage cuts that out. But additionally, it is kind of overlaid on top of the transactional system. So it integrates well. This is a screen that I think really demonstrates a very important part. The audio is here at the bottom. and I can click anywhere and I can hear what word did I say, and then it will sync here, which is the summary, and over here is the transcript, the word for word. So the chief stuff would be in there, and you see it, and it's gone, and the summary. But you can click here, and this summary here, Doctor. So we're talking about the left ear. Here's the left ear popping, and so that it's always referentially trying to validate what it did versus, this question of, well, did it make that up? Did it not hear me right? Most of the time when it's not right, it's because it didn't hear what I said. Oh, I'm sorry. I'm not going to do that anymore. I only have a few minutes left. Okay, so anyway, it can change pronouns, but what do physicians think? This is kind of after every note, and again, I think it's because this is an outcomes trust. 3.84 is the note. That's our data from April when we started to July. And then at the bottom, I've got the latest. We're up to 120 docs using this. That scale that you see there from 5 is perfect, virtually no changes. I get a lot of 5s, and I used it actually last Tuesday. We'll use it tomorrow. It works. I mean, and I think, is it perfect? No, but it is actually pretty accurate. This is how much has changed. And you can see we've got a range of providers there on the right with lots of variation. The average, though, is about 80%. We've seen from that data that I showed earlier, a 21% reduction in time in notes. And right now, our providers today in the primary care world are spending about 10 minutes per note. So, over a whole day, 20% reduction is significant. So I think the value prop here is freedom. And I've been using it since April. I used to take notes to make sure, okay, this is going to be a little complicated. We're going to talk about a lot of things. I write a little bit of stuff down and it doesn't miss it. Now, again, that is such a nice concept to being able to really focus on, conversing with the patient and not the back of my head because I'm playing with the computer. And it really does it's a great response to that comment. I didn't go to school to type, to be a clerical worker. We talked about top of license early on. This is a great example. And so future state, again, I don't think I've got time to talk a lot about this, but potentially the patient aspect of this. I think how many of us leave a physician's office and this conversation about, what did they say? What happened? What am I going to do? I think that's an opportunity that we are already seeing, that we could deploy the same terminology or technology to summarize the note, overcoming the jargon that is medicine. And I don't have to write a 3rd grade level note, but, depending on whom I'm talking to, maybe that's an appropriate conversation. But to have that automated and really improve that conversation. I think I talked about de-jargoning, but also billing potentially. There are many consumers of the notes, and that's one of the problems. In the old days, it was the doctor and the patient. That's what the note's all about. Well, now it's the insurance company and all the lawyers and CMS, and all of those people have drivers that just complicate what the doctor has to produce. So potentially, I think we could address a lot of that. Future states, care caps, maybe we'll talk about this in the breakout. Chart summarization is a excellent opportunity for AI. Help me understand why I need to see this patient, or why am I seeing this patient, what's happened to them, and where do I fit into that? Hunting and gathering is a second biggest time sink. So rural care, that's been a focus today. This is a cloud-based service that's completely accessible. So in potential, in closing, great potential for AI in this, I think, low risk particularly. And, we need to be careful that we don't get out in front of our skis as far as the applications of this technology. And I think also understanding that this is a different really approach than, say, ChatGPT for generating notes. And I think those distinctives matter. Thank you very much.
Good afternoon. So I'm going to try to put a whole bunch of information into a short period of time. Um, my name is Dr. Natasha Bray. I'm the campus dean for Oklahoma State University's College of Osteopathic Medicine at the Cherokee Nation. I would ask for the purpose of this talk that we just all agree to accept that diversity of our physician workforce is important. There's a lot of data that shows that it improves patient care from a population health standpoint. It's really important as we begin to think about who the physicians are that serving communities, that they have an understanding of what was talked about earlier, those social determinants of health. And it is really difficult. I can teach and talk about social determinants of health, but if you're not living in that community, you're not from that community, to begin to understand that there's not self-service, that there's not broadband, that our closest grocery store is an hour away, or maybe our only source of fresh fruits and vegetables is from a dollar store. And how do we talk about diabetics in that care? So if we can accept that, that'll save a little bit of time in this talk, and I'll begin to talk about some of the bigger things. When we think about diversity, we really think about three kind of broad categories. One is experiences, talents, and abilities. The second is cognitive. What are their perspectives, backgrounds, lived experiences that people bring? And then the third is really important, and that's demographics. What's the ethnic backgrounds? What is culture, religion, race, sexual orientation, language, diversity of gender presentation, socioeconomic status, and how do they come into our workforce? And the learners that we have to serve our variety of demographics that we care for as patients. This is where we are today. This is the most recent matriculant data that's out there from AAMC and ACOM, so for our MD and DO schools. And when you look across this compared to our US population, we continue to have some major problems. Our Indigenous population is underrepresented in medical school. Our Black African American is underrepresented, and Hispanics are extremely underrepresented. This is important data. For a lot of reasons, and I'll go through some of it. I'm going to talk to you about our school and the work that we're doing. As was mentioned, we opened in August of 2020, but I think that it's important to understand that this wasn't something that happened out of the blue. Oklahoma State University's College of Osteopathic Medicine was founded in 1972 with a mission to serve our rural and underserved communities in Oklahoma. When we opened this campus, it was really the sum of about 20 years of work. In 2005, we started with clinical rotations with the Cherokee Nation. In 2008, the Cherokee Nation compacted with Indian Health Service to self-govern and self-manage their healthcare system. In 2009, a family medicine residency was opened, and then fast forward to us opening of the medical school in 2020. So I showed you the demographics of what's happening nationally. This is the demographics of our class. 23.8% of our students are Native American. They represent 13 tribes. 31.9% are underrepresented in medicine. 86.7% are Oklahoma residents, and 50% of them come from rural communities of less than 5,000 citizens. So we're talking about our extreme rurals. And why this is so important to us is Oklahoma has some really bad health outcomes. If you look at how we are, we're ranked 46th in the nation. If we look at things like uninsured or preventable, treatable early deaths, we're 47, 48, 49. So we have some opportunities. Every county in the state of Oklahoma has at least a partial HPSA designation. We have 77 counties. We have 3 counties with only 1 primary care provider. We have 6 counties with none. And our average active rate is 74.2 active PCPs per 100,000 population. So what I want to talk to you about is strategies for developing a physician workforce that is really there to care for our vulnerable populations. And when we think about our vulnerable populations, we're thinking about rural, we're thinking about low socioeconomic, we're thinking about our tribal citizens, we're thinking about our urban inner city, and we're thinking about our incarcerated patients that need care in the state of Oklahoma. And really, one of the things that I want to leave you with is that in order to do this, we've got to recognize what the needs are of those communities. We start with what are the needs of the patients that we intend to serve. And this is really critically important because our goal is to recruit students from those communities, support them throughout the educational pathway. And that is a long educational pathway because we start with kindergarten all the way up through supporting them when they're in practice. Because you've heard people talk about if we put people out in a community that they're not used to, they're probably not going to stay. It turns into medical tourism. They drop in, they fulfill their service obligations, and they leave. We want people to anchor to those communities, be part of those communities so that we have that 7-generation impact and that we're changing the life and opportunities of people that are living in those communities. So when we think about our pathway programs for our K through 12, we know that we have under-resourced schools. So our goal is to go into those communities and ask some questions. What are the opportunities to partner with people who are in that community to meet their unmet needs? We really have some pretty simple goals. We want it to be fun. We want it to be longitudinal, and we want to meet the needs of those communities. And whether that is teddy bear clinics and talking to kindergartners about why they need to see their pediatrician, or we're doing forensic fact finders and on a hunt for fingerprints and DNA, we really want to inspire people that regardless of what they go into, that science is fun and it's something that can happen for them. We use our medical students to do this. And the reason why that is so important is we want to take students and we try to match them to the communities. We want to get them out because if I came from that community and I see someone who looks like me, who's had my experience, and they're able to live their dreams, that inspires me to pursue my dreams and to view that as being real. So we want to create that perfect person that Dr. Anderson touched on so that you have more of them to go back to those communities. And that's what it's really about. As we get into our high school-based pathway programs, we become a little bit more intentional. Not that it's not about fun, that it's not about inspiration, but it's about augmenting learning, right? We have under-resourced schools in small communities, and whether we talk about access to lab-based science courses or other challenges, if we're able to introduce those, we're supporting students in success. We want to talk to them about how do I get from A to B? So I'm from a rural community. No one in my family's gone to college. No one's had those opportunities. So how do I even do that? What does it look like if I go to community school? How do I to a community college? How do I come back in? What about our regional universities? So we begin to talk about some of those things. We talk about college readiness. How do we support them in having everything from study skills to the ability to maybe be a little bit further away from home so that they can be successful. And we talk to them about scholarship opportunities. How do we apply for scholarship? Because we know when we talk about attrition in medical school, one of the predictors of attrition is a large debt load going into medical school. So if we're going to get a different population into our medical school classes, we've got to think about that educational pathway. A whole bunch of programs here that are targeted to different communities. Operation Orange is probably the one we talk about the most, or our blue coat to white coat. We're talking about rural medicine. FFA is a wonderful partner for you, for your schools, Future Farmers of America. They have leadership development. So we go in and work with their leadership development courses and talk about how you can use those same leadership skills to come into medical school. A whole bunch of pictures of all of our kids. Undergraduate, I want to touch on this a little bit, and then I'm going to skip through a lot of these slides. When we think about bringing underrepresented minorities into medicine, there's a lot of challenges that they face in the undergraduate environment, and a lot of them are going to give up that dream of pursuing medicine at this point in time. So we need to reach out to our schools and support them. There are financial challenges. If you are a first generation or from a low socioeconomic class and you are having to work to pay to get your undergraduate education, that takes time away from studying, which is going to impact your grades. It takes time away from the opportunity to do extracurriculars. It's going to impact their ability to do research. It's going to impact their ability to shadow physicians. And they don't even have a network to be able to get into to shadow physicians to get those letters of recommendation for medical school. It takes away time that they have to study and prepare for the MCAT. They don't have the money to take the MCAT prep courses anyway. When we talk about holistic review and we talk about removing the MCAT, I just told you all the reasons that a holistic review of that candidate is going to be challenged because they are required to work full time to be able to get that undergraduate education. So we have to keep that in mind and give validity to those lived experiences that they're fighting so that we give them the opportunity to pursue their dream. These are other workshops that we have, and I will talk about any of these with detail with you all, but basically they're all about how do we support them through getting the education that they need, getting those connections to their community so they can get shadowing, paid research opportunities so that they're able to work and meet their family obligations, but they're also able to get added educational opportunities so that it better prepares them to enter into medical school. The other thing that is critically important, if you look at the data of what happens to minority students with healthcare advisors, is they're told that they won't be successful. So we actually actively work with healthcare advisors across our regional university system to support them. We use our ECHO line. If you all know what that ECHO is, it's a hub, and there's my timer, but I'm going to keep talking for a minute more. It's our hub and spokes to get out, and we use that with our pre-health advisors because we want to make sure that they're giving them the information. We want people from all types of different pathways. And this is really critically important. There's not one pathway to success. So we want to support them in getting them there. When we get them to medical school, we want to create a learner-centered environment, one that is based on belonging, academic support, emotional support, financial support, career advising, because we want them to be successful. We put a lot of emphasis on culture. And we heard this touched on by one of our speakers. We want our students to come in and feel entitled, feel psychologically safe, feel like they can belong, and they can bring every aspect of who they are into our learning environment because we need every aspect of who they are. One, for us to engage in a peer learning. Two, to be actually make health differences. We know we have got to address health disparities. There is no way that I can anticipate every holiday that is going to be impacted by our academic calendar, but our academic calendar is 100% based on a Christian, Judeo-Christian tradition and holidays. It does not take into other religious holidays. So how do we support students that have those needs? I cannot anticipate every single tribe's individual cultural things, but I need students who feel safe, feel like they belong, and can identify those needs so that we can support them in going out and being part of their community so that they continue to serve. I'm going to skip through these, but one thing that I will leave you with is we train our students where they'll practice. So we have educational pathways. So we have our traditional academic healthcare center pathway. We have a rural pathway where they do all of their third and fourth year required rotations in rural or critical access hospital systems. We have a tribal pathway where they're done in either IHS or tribally affiliated healthcare systems. This is hard work. We support that education through telehealth and through teleeducation, making sure that they get the key components that they need to develop competency, because we don't want to put them out there and not have checkpoints. So we've got to ensure that they get key information so that they become competent physicians, but we put them in the communities because that immersive learning environment prepares them to take culturally appropriate care of every patient that they're going to encounter throughout their careers. I can tell you all kinds of stories of success. I'm really excited to see you guys who come to my breakout session. We can talk about supporting diverse students and their needs, but really it's not about us as educators. It's about meeting students where they are and creating learning environments that support them in their individual success because they are talented and they have a deep mission-driven desire to improve their communities. And we've just got to get them there. So I will stop with that and say thank you.
I know that we are over a little bit, and if you're thinking I have so many things to talk about, to ask, to discuss, you are heading into a breakout session where each of our panelists will be facilitating those breakout sessions. And just a little additional business, I was reminded to remind you to please fill out the cards on your tables. But I will just maybe do one last reflection, which is, with just 3 speakers, we really hit a lot of different topic areas, from team-based care and using technology in ways to help people deliver care, and to get better outcomes in ways that they will experience healthcare better, to tackling this really challenging, persistent issue of improving diversity in our health workforce, particularly at a time, I'll say, when we are seeing additional challenges in that space. And one of the things I reflect is how do you figure out what you're going to do? If you're going to write something on that card, what are you going to write? And I know that I really emphasize that idea of mission, but we also know, and I think Benjamin from the earlier panel emphasized, mission's not enough. You got to do more than just mission. And I think another word that has come up over and over again today is empowering. Empowering your workers and your learners to be part of the solution. And I'm actually going to quote somebody, Anna Dopp over here, who highlighted to me one time the difference between little a advocacy and big A advocacy, right? That there are things that we can do to change our organizations. There are things that we need to do outside of our organizations. But one of the potential solutions is empowering our workers and learners to be part of those solutions, to identify their priorities, and then to advocate for change. I'm really looking forward to hearing the breakout. I think technically speaking, we're going to be back here at 3:15 for a discussion of the discussions. And I think for the online folks, they can rejoin us at 3:15. And I believe that you should have your breakout rooms on your agendas. Okay, thank you. Thank you again to the